Assalamu alaikum student. We have started CNS medicine in which we have already discussed about the dengue fever and the malaria, and today we are going to discuss about diphtheria. So what is diphtheria? We will start our lecture from a case scenario. So in a case scenario, there's a 20-year-old girl who presented to the OPD with the complaint of fever, sore throat and weakness for 4 days. She had complaint of fever, sore throat, and weakness for 4 days. On examination, her fever was 101 Fahrenheit, and on throat examination, there was a grayish pseudomembrane. There was a grayish membrane with well-defined edges and surrounding erythema. There was a grayish membrane with well-defined edge and surrounding erythema. This was found on examination. So what is your diagnosis? What is the agent causing this condition? What are the investigation and complication? What are the differential diagnosis, and how will we treat this patient? So our diagnosis is diphtheria. The agent responsible for diphtheria is a bacteria called Corynebacterium diphtheriae. It is the most common cause of upper respiratory tract infection. It is most common in upper respiratory tract. It most commonly cause infection in upper respiratory tract. The mode of transmission is transmitted by droplet infection or white skin lesion. In skin lesion, it is most common in alcoholics. And the pathogenesis, the organism remain localized to a site of infection. The site where the organism enter, it can enter through a skin lesion, through a wound, through a cut, or can enter through droplet infection into the respiratory tract. Then it remain localized in that area where it has entered, but it releases a toxin called a soluble endotoxin that damages heart muscle and CNS and leads to several complications. It has been eradicated from many parts of the world. Why it has been eradicated? It has been eradicated due to mass vaccination. Modified exotoxin, the modified form of this toxin, the exotoxin of the bacteria is used in the modified form in the vaccine, and this vaccine lead to the eradication of the organism from the world. Also, the disease is noticeable in many countries like Europe and America, so due to which it has eradicated from the world. But in some area, the vaccination is either incomplete or either not available, like Russia or South East Asia. Then then the infection can occur and can result in clinical symptoms like these. The incubation period is about 2 to 4 days. The onset is insidious, that is, it causes sore throat and fever. So gradually it results in gradual sore throat with fever with tachycardia. The diagnostic feature of the disease is that there will be a wash leather like grayish membrane. There will be a grayish membrane, leather like grayish membrane on the tonsil, and the characteristic feature of this membrane are it will have a well defined edge, it will be firm and adherent. It will be adherent, will not be scratched from this area, will be adherent and firm, and the surrounding will be and it will be surrounded by a zone of inflammation or by erythema. These are the characteristic feature of this membrane, that is, it will have an edge, it will be firm and adherent, and will surrounded by a zone of erythema. There will be swelling of neck leads to bull neck. There will be swelling of neck, which is called bull neck, and there will be lymphadenopathy. On examination, lymph node will be enlarged. In the mild disease, the membrane may not appear, the inflammation may be minimal. With anterior nasal infection, it can result in nasal discharge. The discharge can be blood stain. If it causes infection in the nasal pathway, it can result in blood stain discharge. If it affects the larynx, then the diphtheria is called laryngeal diphtheria and can lead to a husky voice and increase high pitch cough. if we suspect a if there is a history of high pitched cough, and if there is a history of husky voice, we will suspect about respiratory obstruction and will do emergency tracheostomy if needed, because the high pitched cough is an indication of respiratory obstruction. We will examine the patient for respiratory obstruction. The membrane may have obstructed the larynx completely, leads to respiratory obstruction. So in that case, we have to do emergency tracheostomy. The mode of spread of infection, it can spread to uvula, facies, and nasopharynx, and can result in gravely illness in the patient. Within first 10 days, it can result to acute respiratory failure and death due to acute respiratory failure. There are some complication. We have to understand the clinical feature basically in the acute phase. The clinical feature of the diphtheria are basically two. First is the early sign symptom, and second is the late sign symptom. In the early sign symptom, the patient will present with a history of sore throat, with a history of fever, with a history of tachycardia, and on examination there will be a membrane, there will be lymphadenopathy, there will be bull neck, and there will be nasal infection or laryngeal infection, or if the disease has involved the skin, then there will be conjunctival and skin infection. And if the disease present late, if the disease causes complication, then in the complication it can cause ocular palsy, it can result in laryngeal obstruction and paralysis. If it involves the myocardial muscle, if it release the endotoxin, and that endotoxin acts on the muscle of the circulatory system, and the endotoxin reach to the CNS system, it can result in some complication. And these complications are, it can result myocarditis, it can result in arrhythmias, but these can be reversible if the disease is treated, and if the disease is removed from the body, eliminated from the body. So these conditions can be reversible. But if it lead to acute circulatory failure within 10 days, it can cause acute circulatory failure. If we do not treat and suspect diphtheria with time, it can lead to acute circulatory failure and can lead to death. This condition can lead to death. So we have to diagnose it early and start treatment earlier. If it affect the CNS complication, if it affect the central nervous system, the neuron tissue, in 75% cases it can affect the neuronal tissue and can result in palatal paralysis, can result in palatal paralysis followed by accommodation paralysis. So what is accommodation paralysis? In accommodation paralysis, there will be difficulty in reading small prints. The patient will be unable to read the small prints, and in the next 10 to 14 days, in the first 10 days, there is a chance of palatal paralysis as well as paralysis of accommodation, but in the next 10 to 14 days, there can be generalized polyneuropathy. Generalized, all nerves of the body can be involved by this bacteria and can result in weakness and paresthesia, which is a needle and prick sensation. Paresthesia is basically a needle and prick sensation. So how we will manage this patient? We will first take a brief history from the patient. In the history, there will be a history of sore throat, fever, and membrane, and on examination there will be a grayish adherent firm membrane with well-defined itch and with surrounding erythema either on tonsil or on the posterior pharyngeal wall. And on examination, there will be tachycardia, pulse will be more than usual, there will be fever more than 101 Fahrenheit, there will be lymphadenopathy, bull neck, swelling of the neck called the bull neck, and the diagnosis is basically on the clinical basis. On this basis we can diagnose the patient. But if we want to confirm our diagnosis, then we can do culture. We can culture the organism either by taking nasal swab or by taking swab from the lesion. If it has affected the skin, then we can take a swab from the lesion of the skin, and we can take swab from the throat if it has affect the tonsil or the larynx. Then we will take a throat swab. After swab, we can also do CBC. In the CBC, that is full blood count, there will be leukocytosis. Now, how will we treat this patient? A clinical diagnosis of diphtheria must be notified to the public authority. If we diagnose a patient or a case of diphtheria, we will notify it to the public health authority, because if it involves circulatory muscles, it can lead to circulatory failure and death. So it is a fatal disease. So we also, it is a contagious disease. It is a contagious disease. It can spread by droplet infection. It is a contagious disease, can spread by droplet infection as well as by skin to skin contact, direct contact. So we have to notify the authority. The patient is referred to a specialist infectious disease center. The patient will be we will isolate the patient. We will isolate the patient, and we will put the patient on empirical treatment until the results of the culture came, and we will put the patient on bed rest, will advise proper nutrition, will give IV fluid, and will maintain proper ventilation. If there is respiratory obstruction, then we have to maintain ventilation. If it has involved larynx or there is a chance of obstruction, then we have to maintain proper ventilation. We will the patient will be attended by a staff which is properly immunized. The staff will be properly immunized because the disease is contagious. In the specific treatment, we will give antitoxin. The antitoxin is a hyperimmune serum made from horses, and it will neutralize the circulating antigen. It must be injected intramuscularly, but it can cause immediate anaphylactic reaction, and this anaphylactic reaction is characterized by serum sickness, fever, urticaria, joint pain in 7 to 12 days. So after the injection in 7 to 12 days, these signs symptoms can occur. So we will first give a small test dose to the patient half an hour before full dose. If there is any sign symptom of immediate anaphylactic reaction, then we have to keep the epinephrine and adrenaline, and we have to administer the epinephrine and adrenaline, as well as we have to administer antihistamine to cope with the reaction of the antitoxin. The dose of the adrenaline will be from 0.5 to 1 ml of 1 per thousand unit, and it will be given intramuscularly. In severe disease, we have to give a dose of 1 lakh international unit of antitoxin, but in moderate disease, we have to give a dose of 16,000 to 40,000 international unit intramuscularly, while in the mild disease, we have to give 4 to 8,000 international unit intramuscularly. Then we have to remove, first we have give the antitoxin to the patient, then we have to remove the membrane. If it is causing the respiratory obstruction, we have to remove the membrane to alleviate the respiratory obstruction. Then we will give the after the report of the culture came, we have to give specific antibiotic, and the organism specific antibiotic are penicillin 1200 milligram 4 times a day, and it is given intravenously, or amoxicillin 500 milligram TDS per day, and this treatment is for 2 weeks or 14 days. Now, for the penicillin allergic patient, we have to give macrolide group, which is erythromycin. After recovery, all patients must be immunized with diphtheria toxoid, because the disease causes immunity, weakening of immunity in the patient. Prevention, for the prevention, we have to administer the vaccine and the immunoglobulin. The active immunization, that is the vaccine, is given to the children. The close contact are also treated with erythromycin, because erythromycin is more effective than penicillin in the close contacts. in the community, if we are suspecting the disease in the community, or the disease is endemic in an area, then the close contacts are susceptible for the acquiring infection. So we have to give prophylactic erythromycin to these close contacts, and they should be immunized. The close contacts should be immunized, and everyone should receive a booster dose of toxide vaccine. The booster doses are required after every 10 years. Will receive booster dose after 10 years. What are the differential diagnosis? The differential diagnosis include membranous tonsillitis, in which a membrane form, Vincent angina, in which tonsil and pharynx are affected and inflamed, and a membrane also form, aphthous ulcer, and candidiasis. These are the differential diagnosis of the membrane. And the differential diagnosis of the fever, cough, lymphadenopathy, neck swelling are the agranulocytosis and leukemia, while the traumatic ulcer, foreign body diphtheria, and infectious mononucleosis are the differential diagnosis. If the infection is in acute form, we can suspect these cases, and if there is cutaneous diphtheria, then we will suspect in the differential diagnosis there is pyoderma gangrenosum. Thank you. If you people are liking my video, please subscribe to my channel.